Yeah, looks like we still have a few people joining, but we can go ahead and jump right in. Thank you all so much for joining us today. I can go ahead and introduce our guest speaker, Carl Rush. He is a principal consultant at Community Resources LLC in San Antonio, Texas. Carl has specialized in policy and workforce development for CHWs since 1996. He has advised CHW policy initiatives in more than 20 individual states and groups of states for ASDHO and other national organizations. He was a lead author on HRSA's 2007 CHW National Workforce Study and co-lead on the CHW Core Consensus Project from 2013 to 2016. Carl convened the National Conference on Financial Sustainability for CHWs in 2001 and has recently completed 2 national studies with the CDC on CHW certification and workforce development. He is also a member of the National Association of Community Health Workers Policy Committee. So I will hand it over to you, Carl.
Great, thank you, Miranda. Hi, everybody. Just delighted to be with you and just so impressed at the at the turnout. This is clearly the largest group that we've had for this presentation in the country, and it's great to see the interest and enthusiasm. I have a special place in my heart. I haven't been to Michigan in a few years, but I was born in Detroit, and my first job out of college was working at Ford's in Dearborn. So I do have some deep roots. I need to ask your patience today because I'm having a little asthma flare up, so I will be hitting the mute button every so often to cough like now. So I'm going to forge ahead. This if you have not already done so, or if you joined after we took the slide down, please introduce yourself in the chat, and we would like you to answer yes or no as to whether you are a member of the National Association of CHWs. I work with NACHW as a consultant now, but I was also a founding board member. So we're always delighted to make new connections with people, and I urge you to look at the NACHW website when you get a chance. First of all, we got a pretty good response from the pre-webinar survey, and I'm going to just present very briefly some of the results. Large percentage of you are personally familiar with Medicaid, having been a beneficiary, and most of you have worked with people who have Medicaid. I want to acknowledge that we're starting from the assumption that most of you know quite a bit about what I call the front end of Medicaid, which is how Medicaid affects people, their eligibility, the services they can receive, and so on, and helping people gain access to services under Medicaid. But many of you have little or no experience on what I call the back end, which is how Medicaid makes decisions, what it can and cannot cover, and some of the questions about how that fits with what community health workers do, because that is a key question for the day. A lot of people are interested in Medicaid coverage for community health worker activity, and that is a complex topic. So we're just going to get started with that today. So I think people are in general agreement about the things that are kind of good about Medicaid in improving access, reducing barriers to care, and that it is for the most part affordable, and that we've heard in interesting theme in some other states about the fact that simply it is available all across the country and people from all backgrounds can be eligible. Whoops. That's interesting. There we go. Okay, and we're also, I think most of us, quite familiar with the things that people are not so crazy about with Medicaid, about low payment rates and the fact that there are many providers who simply don't accept Medicaid, and that it can be cumbersome in terms of the policies for providers and how they are able to obtain payment from Medicaid. It is complicated. And so we're going to try and peel away some layers on that. And before we're done, I'm going to offer some resources for you online for you to continue studying Medicaid and how it works. And I'm just blown away by this. There are 132 of us on this call. So we welcome you to submit. It's going to be probably too much to have you unmute and ask questions verbally, but if you at any time would like to post a question in the chat or make a comment, please do that. We will be able to see all of those. The things that we don't get to today, we will try to respond to after the webinar. So one of the questions we asked in the webinar survey was how confident you are in what you know about Medicaid. And maybe that question was asked in kind of a simple way. So we may be looking at a combination of what you know about Medicaid services and not so much about policies, but the majority of you are at least at the sort of median level, you might say, in terms of your level of confidence in what you know. So we're going to try and supplement that today and see if we can take things a step further. So what we're going to cover are very briefly the history and purpose of Medicaid. And there are a lot of details in that folks are generally not aware of. The basic eligibility categories and services, how Medicaid pays for services. There are many different ways in which states pay for Medicaid services, and what some of the opportunities and challenges are for community health workers as we look at increasing reliance on Medicaid as a source of payment for what you do. There is a rapidly growing level of interest in the healthcare sector in what CHWs can do. But it is not easy, and we'll talk about some of the things that are sort of built into Medicaid that make it difficult for them to, or not as easy as it should be maybe, to pay for what you do as CHWs. And then lastly, and I think this is really vital going forward, since there is increasing interest in Michigan as elsewhere, that we keep in mind and keep in other people's minds about the choices that are made for Medicaid payment and how they can affect how you do your work. So starting with some basics, Medicaid was created to help to pay for healthcare for low-income folks. That's how it was started. And so it was built to pay for medical care. And of course, we'll come back to this, but you as CHWs do not meet the definition of providing clinical care. So that's sort of one strike against us in this process. But it is also an entitlement, meaning that if somebody applies and they meet the eligibility requirements, that they must be enrolled in Medicaid. And so that's what an entitlement means. And that creates all kinds of dynamics because it is sort of open-ended. In other words, the states have to pay for services that are authorized under the state's Medicaid plan, regardless of how much that ends up costing in total for the year. So the states are very aware of how much they are spending on Medicaid right now, and they are interested in helping to control that spending. And then also, and this is very important, that Medicaid from the beginning was a partnership between states and federal government, and the federal government pays a majority of the cost of Medicaid. So each state Medicaid program is a little different from each other, but they all have federal match. So the federal matching rate varies anywhere from 50% to, I think, 84%. And 50% is what the federal government pays for the wealthiest states, and 84%, and there are a few states up in the 70s and 80s that are lower income states, and therefore receive a higher share of federal funding. I would point out that Medicaid expansion is a special case of this matching, because the states that opted in, and most of the states have opted into Medicaid expansion, that is now, it started out at 100% federal and is now settled at 90%. So the Medicaid expansion population in Michigan, the state receives 90% of the funding needed for that population from the federal government. So very briefly on the history of the program, the basic Medicaid law, what we refer to as Title 19, which is a series of amendments to the Social Security Act, which of course the original Social Security Act goes back to the Depression in the 1930s. And this many people are not aware of how gradually this kind of took effect, but the first support for community health centers and the first recognition of community health workers happened around the same time as part of the overall, what was called then the Great Society or the War on Poverty. It was all kind of packaged together. The states did have to opt in, and they all did. Arizona was the last state to hold out. They didn't join Medicaid until 1983, but I'll go through this in a second, but eligibility for Medicaid has gradually expanded from a very limited set of populations to what we're familiar with today. I mentioned the Affordable Care Act, and that was a big step forward, because prior to that, very few, unless they were elderly or disabled, of course, very few adults without children were eligible for Medicaid services. And so the ACA was a big step forward for families and individual adults. And then, of course, there was the public health emergency declaration around COVID, in which various policies were added to expand coverage in view of the economic and health impact of the pandemic. So that was also a very significant step. And there are some other investments that the federal government made, which have enabled the expansion of the CHW workforce. So it's all been kind of interrelated, and we are now dealing with some of the consequences of the rapid expansion of eligibility and funding under Medicaid in recent years. So eligibility is, I think most of you know a fair amount about Medicaid eligibility, but it didn't all happen at once. In other words, the way Medicaid looks to us right now has not always been the case. And even before the 1965 Medicaid legislation itself, the federal government began paying for nursing home care way back in 1950. And it wasn't called Medicaid, of course, at that time. And still, Medicaid is the largest single payer for long-term care, including nursing home care in the country. The 1965 amendments that I just mentioned were on the previous slide were added what we call categorical medical benefits, which is actually paying for medical care or clinical care. And it was categories of eligibility based on income. The very first recipients or beneficiaries of Medicaid back in the 60s were what we used to call welfare recipients, only to people who receive cash assistance, which is now called TANF, and that was it for a number of years. Then there came along some further amendments, including the child care benefit added in 1967, which is a very significant part of the program today. Pregnant women and children were not really officially part of the program until 1989, and a lot of people don't really know that. Older kids were then added the following year, and you can begin to see a pattern here that the federal government is very interested in children and labor and delivery and the well-being of pregnant moms and so forth. But then there was additional coverage added in 1997 for what we came to call CHIP, for kids and families with incomes with just a little above the Medicaid limits, which was, you can see that the federal government has had a priority in attending to children's health, and in the belief that it helps to assure longer-term health for people as they become adults. So there's been a lot of emphasis on coverage for kids. And then, of course, I mentioned the Affordable Care Act. So one of the crucial things to remember, and many of you are very aware of this, that the income limits for eligibility in Medicaid depend on what eligibility category or recipient category you're talking about. So we're going to pause now and let you do a little more of the work here. We're going to go into small groups in a minute, and it's actually because of the size of this group, we're going to need to have larger groups. It's terrific. But we're going to have, let's say, hopefully groups of 6 or 7. And you'll have about 10 minutes. And what I would like to have you do is prepare to post some comments about your discussion of the following questions. And so, again, because of the large size of the group, we're not planning on having you unmute and ask questions verbally. But if you could designate somebody in your group to take notes and just post just a couple of brief comments on interesting things that you have observed in your group, things you heard in the group that were interesting, based on the following questions. And I'm going to ask Miranda in just a minute to put you all into groups. So here are the questions. What is one thing that you individually know about Medicaid that you think others in this workshop might not know? So are there any things that you can share with your small group that you think they may not be aware of? Because you are in many ways the experts in this webinar. And then what's something that surprised you about what we've already discussed? So Miranda, I think we're about ready to go into small groups. And if you could please go ahead and move people to those groups. As I say, you'll have about 10 minutes. How we doing, Miranda? Everybody okay?
It looks like everyone's been assigned.
Yeah, they're starting to file into the groups now.
And I have them set to close after 10 minutes.
Okay, great. All right, we still have 17 people in the main room. 16. Looks like about 8 participants still not in small groups. I'm not counting the co-hosts here.
Yeah, they are assigned, it looks like.
They just haven't joined. Oh, there we go. Folks, if you're just joining, we're in breakout sessions right now, and if you just joined, you may not be assigned to a small group yet. But if you have
I've
an
been trying to
invitation,
keep up, and if people are joining, trying to assign them.
yeah, I know that's going to happen. That's normal. But everybody who was on okay, there we go. Here we go.
I think it might just be new joiners. We've got about 2 minutes left.
Okay.
And then I think everybody will come back.
Okay, folks, if you're just joining, the rest of the group has been in small group breakouts and we'll be rejoining in a second. But if you have not done so already, please introduce yourself in the chat, your name and organization, and whether you are a member of the National Association of CHWs or NACHWA, just a yes or no. Thank you. By the way, I'm just amazed at the numbers, the participation level. That's quite remarkable.
Yeah, I'm really, really excited about the turnout.
I didn't ask, but should have. Do you, or you want somebody else on the part of a Michwa to say anything about your interest in expanding your policy initiatives relative to Medicaid?
I will probably include that in a follow-up.
In a follow-up, okay.
All right, the room should be closing in a few seconds here.
Okay, folks, as you're returning, if you are the designated person or you just want to post something in the chat about what came up in your discussion with your small group, please go ahead and do that. Okay. So it looked like everybody's back, Miranda?
Yes, I believe so.
Okay. Okay, great. Well, thank you all for digging in for a little. We want to try to encourage the dialogue among yourselves since this is a large group. It's mostly going to be me talking at you, but we do want you to be. There's going to be another breakout in a little while, but we do want to encourage you to discuss these things now and after this webinar amongst each other. And so again, if you have somebody designated, please have that person enter a brief comment about what came up in your group. We are very interested in your responses to these questions. So I'm going to forge ahead here in just a second. All right. Now, I did want to add, and some of you may be, again, familiar with these, but just want to say briefly about some, apart from the big eligibility categories that that you all are quite familiar with, there's some other special cases that don't come up so often. I'm just going to mention them quickly. Dual eligibles. There's a small percentage of people who are eligible for both Medicaid and Medicare, and there are special rules for them. Most of them receive services under a fee-for-service payment mechanism, but that varies a lot from state to state. There are some provisions in Medicaid to pay for undocumented folks that and many states have rules about being able to pay for labor and delivery for undocumented folks. There are even if they are undocumented, the Medicaid will pay for some emergency services. For people who are currently incarcerated in prison or jail, that certain services can be paid under Medicaid. And then foster kids, this is interesting, the Affordable Care Act really authorized for kids in foster care that they can continue to receive care under Medicaid up to age 26. And a lot of people are not quite aware of that. Now, I mentioned earlier that the income limits for eligibility for Medicaid depend on which of the eligibility groups we're talking about. Many states cover people at higher income levels than the federal government requires them to cover. And so you can see, though, that children and pregnant women are a big priority for Medicaid because people at somewhat higher income levels can be covered in these eligibility categories. But others, in terms of like elderly and disabled and parents and so on, the income limits are quite low in terms of what the federal government requires the state to cover. In the case of Medicaid expansion, these income limits are generally higher for that population, but they are higher only for the people who are eligible under Medicaid expansion. What the states actually do over here is that I don't know what that little black line is doing there. That's interesting. But you can see that some states cover some of these eligibility categories at substantially higher income limits. So, for example, there some of the highest paying states, the income limit for eligibility for these groups is over 300% of the federal poverty line. So this varies. I didn't get into the details of what Michigan does. Many of you are quite familiar with those, but it does vary a lot from state to state. And these are clearly, obviously, wealthier states that are able to cover these populations at such relatively high levels of income. Now, here's where we get into the real nitty-gritty about what we're discussing here today. That Medicaid, and Michigan is no exception, that states use a mix of payment models. We talk a lot about, in quotes, reimbursement. And that is, by definition, reimbursement is paying for something after it has been delivered. So that the provider is reimbursed for the cost of services that they have delivered already. So that's not always the case. And there are payment systems where the providers are paid before they provide the services. And that is a trend that is ongoing now and increasing, I think. So fee for service is what I just described as reimbursement. But we also have managed care, which you do have in Michigan. I believe 10 managed care companies, 10 managed care plans. And there are also what we refer to as alternative payment models. You'll hear this a lot. You'll hear a term like value-based payment. And what they're trying to get away from, and things like accountable care organizations, the prospective payment system, this is, some of you I'm sure know this very well, those of you who work for health centers in particular. Across the country, most federally qualified health centers, or FQHCs, are paid on a prospective payment system. Now, this doesn't mean they're paid in advance. It means that they get paid per encounter or per office visit, a set amount, which is based on the total cost of providing care. And this is somewhat unique to the health center movement. It's a historic thing. And the basic point is that they bill either a Medicaid health plan or the state on the basis of, excuse me, this is going a little bit haywire here. They get paid a set rate per visit or per encounter, as they call it, based on a calculation of their total cost of providing care divided by the total number of visits that they expect that year. And that is, as I say, unique to them, but that is likely to change. And I'll come back to that as well. Again, if you have comments or questions, please post them in the chat. I want to pause maybe at this point. Miranda, have you seen any questions that maybe we should address before we go further here?
Yeah, just one. Someone was asking about what exactly Medicaid expansion is.
Okay, I'm not familiar with the experience of expansion in Michigan specifically. I see somebody has commented on that. There's a later comment. Did you see that, Miranda?
What was that?
Sorry, somebody responded about in April 2014, Michigan expanded Medicaid. It's called Healthy Michigan.
Right, yeah. I'm not sure who had asked the question, but if they could let us know if that covers it.
Okay. Yeah, basically what the expansion did, right, it allowed the states to do it. There's still, I think, like 10 states, something like that, that have not expanded Medicaid, but it allowed the states to authorize payment for care to more childless adults. In general, you had to be a parent in the past to be eligible for Medicaid. It also provided for coverage uh, of kids under their parents' health coverage if they until they were reached age 26. There are a variety of other provisions for that. But one of the big impacts is that more adults, more non-disabled adults were covered under expansion than had been the case before. And you can certainly do your own research on that. There's plenty of stuff online, but most states have found that expanding Medicaid has been a net economic benefit to the state. That there has been some more spending, but there has been more economic benefit to the state from covering these additional people. So quick, I made some comments about fee for service. That is what classically what we mean by reimbursement. And so you go to a doctor's office, they submit a claim for that visit, and they get paid a set rate for the services that were provided under that as part of that visit, excuse me. And even the states that have managed care, as Michigan does, Michigan about the 60% of Medicaid spending in Michigan goes through managed care companies, but particularly long-term care, most states still provide some services under fee for service. What that does, however, is it means that providers who are paid this way have an incentive to encourage the use of more services. In other words, they get paid more the more services they provide. And so it's to their advantage for patients to come in more frequently for more visits, for more services. More services equals more revenue to those providers. And what many states are saying is we don't want to be stuck paying for more services just because they can bill for that. We want to encourage providing better quality care as a value, paying for quality, paying for performance, which we'll come back to in a moment. Managed care, of course, you're familiar with. In most states, it's a combination of the state paying fee for service to some providers, but also paying monthly payments, what they call capitation, which is basically an insurance premium. The state is paying insurance premiums for these individual recipients. The managed care company takes responsibility for providing most, if not all, or paying for most, if not all, of the services that their members receive. And so the managed care organizations take this monthly revenue that they receive and they pay some providers on a fee for service basis. And on some providers are paid in advance a certain amount to cover all or a certain number of types of services. But that's basically how managed care operates. And so they take their premium revenues. And by the way, the premium levels are different for each eligibility category. For example, the premium or the capitation payment that the managed care organization receives for young children is generally pretty low. Most young kids do not have a lot of healthcare expenses or needs. So the amount that the health plan receives for those young kids is generally lower than it is for other eligibility groups. Now, the managed care organization must pay for most of their member services out of that revenue. There are some things that are what they call a carve out, where the state says we're going to pay for these things separately. And this could be behavioral health services or dental services or things like that, that they pay for in another way rather than the managed care organization being responsible for all of the services that their members receive. Now, an interesting thing we're seeing, we don't have any hard data on this right now, but many health plans pay for CHWs or employ them on their own volition, if you will. They have taken the initiatives to do this because they know that CHWs can improve care and help to control costs. And so they're willing to, the MCOs, health plans, have limits on how much they can spend on administration. And they are willing to pay for CHWs out of that administrative budget, if you will, because it makes business sense to them. And so even if the state does not authorize them to pay for CHW services as medical expenses, as part of the cost of care, they can still spend that money as an administrative expense without asking for any permission or authorization. They can just do it. Again, Michigan is a little bit of a special case, which I'll come back to in a second. So the general rule out of all of the payments that the managed care company receives over the course of a year, they generally are not allowed to spend more than 15% of that for administration. Okay, but if they do the calculation, say, we can get some benefit out of spending this amount of money as an administrative expense without violating that limit, then many of them have decided, yes, I'm going to go ahead and do that. Excuse me. So it is estimated that 85 no, I don't sorry, please disregard that. I did not track down numbers on this, but in most states, the percentage of recipients who receive services through managed care organizations is somewhere in the range of 70 to 80%. And I have to apologize. I was going to research this further, and I could not find a number in terms of what percentage of Medicaid recipients in Michigan receive services through managed care. I said earlier that 60% of the state's Medicaid spending goes through managed care organizations, but that doesn't mean that 60% of recipients have their services paid for through Medicaid health plans. So we can probably look up some better numbers on that. But I do have to apologize. I was not able to find that before we got to today's presentation. No. I mentioned a minute ago that Michigan is somewhat of an exception. To my knowledge, Michigan is the only state that has done this. But going back some years now, the state has in their contracts with these Medicaid health plans, they require them to offer CHWs to their members. And this is done currently, I believe the ratio is they have to have at least one full-time equivalent CHW per 5,000 members. That original number was quite a lot higher. I think it's 15,000, 20,000. I don't remember for sure. But when this was first instituted, it was one per a larger number. It is now one per 5,000, which doesn't sound like a lot of CHWs to serve their members, but this was required as the health plans were required to pay for these services as an administrative cost. Okay. And so that meant that the state did not have to go to CMS. They did not have to go to the federal government to get approval of this. Okay, since since they are directing this as an administrative expense under the health plan's contract, they did not have to get this approved. But as I understand it so far, the implementation of this has been kind of mixed. In other words, not all the health plans are interpreting this requirement in the way that it was intended. And there really are no standards for what services must be provided, and that there are no standard qualifications for the CHWs who are employed under this provision. So the best I can gather is the results of this have been somewhat disappointing. The good news about this, though, is that people have been talking about this enough that there is a renewed interest, and at some point after this webinar, there will be opportunities for you to get involved in figuring out how the state could do this better, could make better use, get more benefit out of what CHWs can do through a different kind of financing mechanism for CHWs as services. And so what I have been hearing is that the quality of services that are provided by the health plans under this requirement varies widely. Some people are doing a pretty good job, and others are simply not not rising to the occasion, if you will. They are either not employing actual CHWs, or they are asking them to do things that don't take full advantage of what CHWs can do. And so that is disappointing to hear that. So there are opportunities for Michigan to do better here, clearly. I mentioned alternative payment models. This is something that states are talking a lot about. They are not necessarily moving very rapidly to implement these, but alternative payment models create incentives for service providers to focus on quality, access, and health equity. And those are all welcome developments. But how do they do that? And the way they do that is to pay per value in some form, to pay for certain outcomes, like the percentage of patients with diabetes who have their diabetes well controlled. That's a measure of outcomes or quality of care that the payer, in this case the state or the health plan, can make it clear that what they want to pay for are these kinds of results. Okay. Now, there are a lot of different models out there. In some states, they have bonuses, they have quality measures, and if you reach or exceed those quality goals, you as a provider can get bonus payments. And so that's an incentive to do a better job. There are a number of services that are now being paid for things like joint replacement, a hip replacement, a knee replacement, where they calculate what it ought to cost to do that, which includes things like surgery and rehab after surgery and things like that, and that as a total should cost no more than X. And so we will pay X for knee replacement. period. And if you can make money by, offering all of those services at appropriate quality for less money, then you get to keep the money that's left over. Now, when they're talking about things like accountable care organizations, you get paid for let's say a certain range of care, of services for individuals. And if you provide all of the required care at a lower than expected cost, then you keep the profits. If it costs you more than average to care for that patient, then you absorb the loss. So that's what financial risk means. And this is what they're trying to get people to agree to, under the assumption that the way you make a profit is to provide better than average care. Okay. And so you do well financially by providing better than care that's better than it has been provided in the past. And the ultimate form of alternative payment models is paying a capitation payment, again, like a premium per member per month, and you would get paid in advance for that. And again, that's an incentive to be proactive, to work with those patients, to keep them healthier, so that you end up having fewer costs for actual acute care for those members. And so I understand that in Michigan, the Medicaid health plans are starting to use these kinds of alternative payment methods with providers. And that's very interesting. And what it offers is the opportunity for those providers to employ CHWs to help them meet their quality goals and continue to make a profit. And so that is something that the providers in this evolving system, these providers are going to start to find attractive about CHWs. So I want to pause. We're going to do small groups here again in just a second. I want to ask Miranda, do we have any additional questions that we should probably respond to before we go in?
There were a couple, but we've got some helpful people in the chat, and I believe they were responded to, unless there was something that I missed. So if I missed your question, if you could go ahead and use that again, that would be helpful.
Okay. Okay. I see. Okay. Well, there are, I do want to encourage you to respond to each other. If you see a question in the chat that you can answer, by all means, we want to encourage you to be learning from each other as well. So that being said, we should probably move along. We're going to do this essentially.
It looks like there was one. What are some examples of MCOs?
I'm not seeing it. I can't scroll through fast enough.
It says, what are some examples of MCOs?
So somebody want to enter something in the chat about, I assume that's asking for names of the healthcare companies. There probably would be like Blue Cross Blue Shield, and I think Molina is in the Michigan market. Okay, that's something that's very easily, you can look up very easily after the webinar. Okay, so we're going to move into this second breakout here, and we can go ahead and give you 10 minutes. It says 5 minutes here, but so I would like for you to share with each other what's the most significant thing you've learned so far about how Medicaid pays for services. And it could be, you could have a further question about that you want to discuss in this group, and that's fine. But if you could please share with each other the things that you think are significant about what we've been learning so far about how Medicaid pays for services. Okay? So
You said you wanted it for 10 minutes?
yes, let's do it for 10 minutes again.
All right. Okay, those have been assigned.
Filing out of the room.
Got about 2 more minutes on the breakout rooms.
Okay, good.
Meeting is being recorded.
It looks like everybody should be filing back in.
Okay. Yeah, it looks like most folks are there. So would like to ask you again, somebody, either a designated person, or if the spirit moves you, go ahead and type it in yourself to enter into the chat a comment in response to this question. What came up in your small group in response to this question? We are very curious about this, and before we wrap up today, going to encourage you to think about how you might want to continue this learning process together. We're really just at the very, very beginning of a learning process. So please go ahead and enter those comments into the chat. We'll get started in just a sec. Okay. Great. Sees lots of great comments in the chat. Thank you really for your engagement in this. So we're going to get going here again and talk and get down to the real nitty gritty. First of all, some of you may be aware of the numbers on this, but Medicaid is a pretty big deal. I'm going to say this again later, I'm sure, but to keep in mind that that Medicaid is never going to be the only answer for financing CHW activity. And there are multiple reasons for that, but we will probably always have to look at some form of combined funding with other sources. However, at the national level, this is a pretty big deal. In fiscal 2021, total Medicaid spending was over $700 billion. And of that, about a third was from the individual states. And this, in some states, this is the single biggest item in the state budget. Either the first or second. Sometimes K-12 education might be the number one item in the state budget, but Medicaid is right up there. The point is that states have limited control over Medicaid spending because it is an entitlement program. And if people keep enrolling and keep using services, the state's expenditures will continue to go up. The numbers I've been able to find for that same year, Michigan is still, it's pretty big for an individual state, over $16 billion, and 60% of that funding, as I said earlier, have gone through managed care. There are about 2 million total recipients in Michigan, and the federal government pays a 65% match for original Medicaid in Michigan. As I mentioned earlier, the Medicaid expansion populations, the federal government share is still 90%. So that's an incentive for the state to maintain the Medicaid expansion. So where does the money go? And this is an important distinction, that the vast majority of Medicaid recipients, and this is pretty similar across states, but the adults and children are close to 80% of the individuals served by Medicaid. But the elderly and disabled, the other 22%, account for 62% of the expenditures. And that makes sense when you think about it. The people who are older, have a disability, maybe both, that they have greater healthcare needs than younger populations. And so just for comparison, a little bit more detail here, because this includes both expansion and regular Medicaid. In Rhode Island, I was able to get a further breakdown so that the expansion population in Rhode Island was 25% of the, whoops, this is really sensitive here. The expansion population was only 25% of the recipients, but they were an even smaller percentage of spending. So this is a benefit to the state because they're adding a lot more people, but they're not expanding the spending as much. This may be a little complicated. You may need some time to study on this. But again, this is hard to compare with the Michigan data. I could not find something similar to the Rhode Island breakdown in the sources that I had for Michigan, but that I had for Rhode Island. This thing is just really squirrely here. Okay. But I guess the point is that we need to be thinking about where you devote your attention, where your energy goes. where you're going with advocacy, where you're going with, or how you're spending your time, how your organization is spending time working with these different populations. In a lot of states, there is a particular interest in working with high cost recipients. And a lot of times we don't talk about this, but there's some interesting issues that it stands to reason. There are some people eligible for Medicaid who have a lot of need. They account for a lot of spending. And that's sort of related to the previous slide. But the point is, there are states like New Mexico where they have focused their attention on a care coordination program for the highest cost recipients in Medicaid. And CHWs have had an important role in that going back 10 years or more. And they have shown that by providing better care for these high cost recipients, the state can actually save money. So the way this breaks down, Rhode Island is one of the only states that I've been able to find that does this kind of breakdown for high cost enrollees. And this is very dramatic here. You'll see that in Rhode Island, the high cost enrollees are like 9% of the total people eligible for Medicaid. And yet those 9% of the people account for 73% of Medicaid spending in Rhode Island. Now, as you can imagine, the state and the managed care plans would like to get at these expenditures. And it is true that there are things they can do that will help to reduce the cost of care for these high cost enrollees. But we do want to ask the question, and the definition in Rhode Island is someone who accounts for $15,000 or more per year as an individual, actual cost to Medicaid. So that's, again, a small number of recipients, a small number of enrollees, but they're accounting for a huge percentage of cost. So I think it's obvious why the state would be interested in this, of course. And the interesting finding, though, when we get down to talking about how to approach this, is that there's a fairness issue. If you devote all of the attention of your community health worker activity on these high cost enrollees, you're only benefiting 9% of the eligible population. And is it fair to deny the help of CHWs to the other 91% of enrollees? I would encourage you to put that conversation in your agenda for future discussion, because that is a legitimate ethical issue. It's a legitimate fairness issue. So it's worth discussing. But the big question is, how can you as community health workers help to address this situation? We're not going to answer that question today, but this is a really interesting opportunity for you to talk to Medicaid, to talk to the health plans about how CHWs can help them reduce the cost of these high utilizers, you might also say, in Michigan. So if all of this makes so much sense, why are our CHWs mostly not covered by Medicaid around the country? And it is true, the number of states that are doing things with CHWs is growing, but it's still, in most states, CHWs or services are not officially covered by Medicaid. Going back to the very first slide in the presentation, Medicaid was created to support health care for low-income individuals. And technically speaking, CHWs don't provide health care. They don't provide clinical care. And I'm going to show you very briefly a table in a minute of the services that the federal government requires all states to offer to Medicaid eligible individuals. Most states offer additional optional services. Yes, that's true. But the federal government does not require any services that CHWs can really contribute to. So that's a little bit of a problem. Community health workers are also not defined as providers in the Social Security Act. And of course, that would be a helpful thing for the government to change, to add CHWs as a class of providers. However, that being said, there are other occupations like doulas and peer support specialists that can provide an example showing a way toward a Medicaid reimbursement. We know that certainly peer support workers, peer support specialists in many states, easily 20 or more states, authorize Medicaid to pay for a peer support specialist. An increasing number of states are supporting doulas. And I have learned, for example, that Michigan Medicaid does pay for peer support specialists and has for quite a number of years, and that there is interest now in authorizing doulas for Medicaid payment. And this is encouraging because the core competencies for both of these professions are very similar to the core competencies required for CHWs. And one of the strategies that folks are taking in other states, and you should consider in Michigan, is tying these occupations together and saying that there's clearly a lot of overlap in the skills that are required for all of these professions, and that the difference is what kind of lived experience is required to be successful for each of these occupations. So there's clearly some discussion. Is there a way to leverage the state's interest in peer support workers and doulas by showing them that CHWs can reach broader populations, can provide an additional range of services beyond what doulas and peer support specialists already provide? So how can this fit into your strategy? Again, to capitalize on the interest that the state has in these other occupations. So I promise this is I'm not going to get into the details of this. You can look at it later. But these are the mandatory benefits that the state requires, the federal government requires for all states to offer to Medicaid beneficiaries. The first column is traditional Medicaid, and newly eligible has to do with expansion. Okay. And then there are optional benefits that states may offer. They have to specifically authorize them. The only ones that really make sense in terms of CHW roles has to be things like case management or diagnostic screening, or mainly screening, services, possibly something under home and community-based services. So there's some opportunities here, but what is understood, what is offered by the federal government as options is really not enough to cover the range of things that CHWs can do that would be beneficial to the Medicaid program. Now, all that being said, a growing number of states are pursuing Medicaid financing for CHWs. So why is that? Several things. As mentioned earlier, and this again is totally understandable, that the states and the federal government are under pressure to improve the quality of care received, quality and access to care, actually, under Medicaid, and to help control costs. And we have seen from the evidence that community health workers can help them do this. There is also a lot of very welcome interest and emphasis on health equity and social determinants. And the argument for CHWs is increasingly relying on this, that people in healthcare, not just under Medicaid, but in healthcare generally, they are interested in these issues. And you can help all of these folks to implement an expanded emphasis on health equity and social determinants if they understand truly what you are capable of doing. And I say that, I emphasize that quite a bit because they really need to understand the definition of CHWs and what you can do. But these are very welcome trends. Now, at the same time, there is another big shift in healthcare generally, and it is definitely playing out in Medicaid, is that the general sort of model of what healthcare looks like is changing. Traditionally, we have had a transactional system. And by that, I mean, you experience a need, you experience a health issue where you feel you need healthcare services to help you respond to it. You seek out a provider of care, you receive care from them, and somebody gets paid. Okay, either you pay the doctor or your health plan pays the doctor or Medicaid pays the doctor, whatever. And you walk away. You get a service, money changes hands, and you walk away. That's called a transaction. And sometimes I like to refer to the way we have treated healthcare as like a vending machine. You walk up, you put in your money or a piece of plastic, and you get a service and you walk away. And I'm sorry, I couldn't resist the irony of making this a bacon vending machine. But at any rate, this is changing to a relationship-based system. And people are under pressure within the healthcare field and in public policy to make healthcare more relationship-based. And so what that means, we hear a lot about patient-centered care or family-centered care, but relationships are crucial to making this happen. And why is that? It's because this kind of relationship requires better communication. It requires trust. Okay. And so the good news is that you, community health workers, are experts in establishing trust and communication with low-income and marginalized populations. Trust is crucial for relationship-based care, and yet there are problems with trust among low-income populations and people of color. That is based on at least two things. One is that there's a difference in perceived power between a medical provider as an authority figure and a low-income individual. And there's only so much that that provider can do to help to break down that barrier, that they are assumed to have all or most of the power in that situation. And that's hard to overcome. Okay, in order to establish that trust and candid communication. Okay, the other big issue in trust is among the populations that you serve, and I'm sure that many of you will nod your heads at this, that there's also a historic mistrust in institutions, and especially like hospitals. And so those things are hard to overcome. You need somebody who enjoys the trust of that community in order to develop those relationships. So I'm sorry, I did not correct this. My last presentation was last week in Kansas. So let's just picture that that's Michigan up there. So in order for that to happen, you're going to need to decide what things that CHWs do are most important to Medicaid. Okay, what can you do that Medicaid would value the most? And it's for you to discuss with them, with the state, with other interested parties to make that decision. What are the things that you can do that will be most important to Medicaid? And then decide on a payment method. I have to say, in all honesty, most states are starting out authorizing fee-for-service payment for CHWs, which is not a great fit for how you work. We know this, but they have other reasons. It's hard for them to set rates for other methods of payment without knowing what the actual expenditures would be, or what the actual utilization of your services would be. So once you've made all those decisions, somebody needs to estimate the costs. And it is also possible at this stage to make some pretty good estimates of cost savings resulting from what you would pay CHWs to do. So it could be savings in terms of reduced hospitalizations or reduced episode of, let's say, low birth weight or premature delivery for newborns, things like that, that the cost and estimated savings need to be estimated. And that requires a lot of sort of inside knowledge. Once all those things have been decided, a proposal needs to be approved by the state and reviewed by all of the interested parties involved in the state, and the final proposal being sent to the federal government for approval, mostly as what's called a state plan amendment. There are some others, and almost every state has had some Medicaid waiver activities. I won't go into that right now. It's not an ongoing source of support in itself, but that there are need to get these things approved by CMS, usually as a state plan amendment. So here's where we have a real opportunity, and this is I'm going to be wrapping up here in a few minutes, but I want to spend some time on this because you are likely to be involved sometime in the very near future in discussions with the state, excuse me, and with the Medicaid health plans about what you would like a payment program for CHW services or a CHW benefit, what you would like it to look like, because there are some important things in these decisions. Whatever the state decides to pursue, it can have profound effects on your actual work. And that brings me back to the real purpose of this webinar, to start a process. The process that I just described of developing a plan for Medicaid to pay for CHWs has a lot of steps in it, but you as CHWs, as MICHWA, need to be at the table with the people who are making these decisions. And this slide, I'll get to it in a second, I promise. This decision about what the state will pay for and how they will pay for it, affects you directly. So if for no other reason than that, you must be at the table to talk about what you need and how these various options that the state has might affect your work. So this, if you've been multitasking during the call up to this point, I really encourage you to focus your attention. The reason we developed this webinar is that you must be at the table in making these kinds of choices because it affects your work directly. But if you're in that room, you're going to be in the room with a bunch of policy wonks like me, or a bunch of healthcare financing experts who are going to be throwing around all kinds of jargon and technical terminology. And we want you to feel as comfortable as you can be with those conversations, for you to have an understanding of basics and be willing to ask questions. And when people are throwing things around that are new to you, that you have the right to understand what they're talking about. So all that being said, sorry, I don't have a drum to do a drum roll, but here we go. So clearly it's important that there are, the state has to decide what services will be covered. I will say right now, and this is not on the slide, but if you're taking notes, this is a good time. The states have been willing to authorize payment for three big categories of activity. One is health education. That should be no big surprise, no big whoop. The other is health promotion and coaching, which can mean a lot of things, and there are a lot of things that you could fit into that category. So health education, health promotion, and coaching. And the third is navigation and care coordination. And there are a lot of variations in those three things. And I'm making a mental note. I need a slide on those three things because that's the pattern that's emerging in the states that have added CHW benefits in recent years. That's what they have either authorized or are proposing. And there are a lot of things that you can incorporate under those categories of services. There are a lot of things you can do. And for example, being part of a care planning or care management team, of participating in screenings or doing assessments of home living situations, of coaching patients during a visit with a provider. All of those things can be captured under one of those three big buckets of services. So that is one of the biggest and most fundamental decisions. And if you look at examples like what most recently Rhode Island and California included in their state plan amendments, they have gotten real creative about what they want CHWs to be able to do under those three categories. The three most recent states are South Dakota, Louisiana, and Rhode Island, approved fairly recently. California has a very similar proposal that is in review at CMS now. So, but the services covered are very similar. Next big consideration: is there going to be a limit on how much billable time you can spend with an individual or family? Okay. It could be a limit in terms of hours or units of service. The states generally define units of services like either 15 minutes or 30 minutes, but it comes down to how many hours can you spend with that patient or family over the course of a day, of a month, of a year. Rhode Island, very interestingly, decided not to have any limits of that kind. It is their belief that this is not going to get out of control just because they have not proposed any limits. But this does affect, I'm sure you can imagine that you would be concerned about not limiting the amount of time you can spend. So for example, if the limit is, if there, I'm hearing some background conversation. If you're not muted, if you could please mute yourself. So the a total of 2 hours a day. And they pointed out that there are some diabetes management classes where people attend for 4 hours a day. and they wouldn't be able to bill for all 4 hours like that. Next one, what is the hourly rate of pay? Of course, that is a concern. I think all of us and NACHW certainly strongly supports movement toward a living wage level for CHWs. But what you actually get paid in terms of a salary is only part of what is billed to the payer. Your employer needs to bill for other things like supervision. They need to allow for some non-billable time that is essential to what you do. And I would just point out one part of that. One is, I think you all know that part of what you do is spending time developing a relationship with that individual or family. And time spent developing a relationship by itself is not billable. So there will be, your employer will have a cost paying for your time doing that work that they can't bill directly to the payer. And so you need to build an allowance for that non-billable time into the billing rate for what you do. Other costs like, training and information technology, all of that kind of stuff, all needs to be covered somehow. So the hourly rate of pay, I think you're probably already aware that most providers will say that Medicaid payment rates are too low for everybody. And so that's a reality, but this is an important negotiating point when you talk about what the state's going to propose to authorize in terms of Medicaid payment. What settings will Medicaid pay for your services? There are basically three. One is just out in the community, one is in a clinical setting in a health center or hospital, and one is in home and doing home visiting. And it affects your work in terms of what Medicaid will pay for. In some states, people have argued against CHWs being able to provide services in a clinic or hospital. I think they anticipate some conflict with other professions. They're saying that CHWs can't be paid for services in the clinic. Some people say just the opposite. There's some interest groups, including some employers, who say that the CHW can only we can only bill for CHW services in a clinical setting or in the setting of the employer agency. And that's generally people who might be supervisors who are nervous about CHWs being out and about in the community on their own. That's a separate set of issues. And again, Rhode Island has been fairly progressive on this, and they will pay for services in whatever setting. So, for example, if the employer allows CHWs to provide transportation for the patient, that they can do health promotion and coaching on the bus or in the car with the patient on the way to an appointment. So there are lots of creative ways of dealing with that, but settings will be an important part of the discussion. Who may authorize CHW services? That may mean what providers are allowed to refer a patient to receive services from a CHW, or to order services to be provided by a CHW, or to recommend who must supervise the CHW. These are really important choices for you to make, and different organizations will have different preferences, but this is a really crucial consideration. It also has some things to do legally with what the federal authority for payment is, and that's a little bit technical. We don't really have time to talk about that today, but there are a couple of different ways that these services can be authorized under Medicaid regulations at the federal level, and that's an important decision here. So, and then lastly is how will we deal in CBOs, community-based organizations? A large percentage of CHWs are employed by CBOs and not by healthcare organizations. And how will they participate if they have not been connected to Medicaid before? Being a billing provider for Medicaid is a huge burden, a huge hurdle, especially for small organizations. So are there creative ways that folks can be engaged, that CBOs can be engaged through partnerships, through third-party billing, through a variety of things like that? I do know, having worked recently with California and Rhode Island, they spent a lot of time and very sincere effort to try to work with CBOs to figure out how this is going to happen. So there are other considerations, of course, in designing a payment program, but these are some of the most crucial that you all need to be at the table to talk about with other interested parties. So I would like to leave you with some resources, and I know that there's going to be more activity involved in planning and advocacy around working with Medicaid. I encourage you to get involved in those activities, but to do some studying on your own. There are lots of opportunities. You have some very unique examples, experiences with some of the early Pathways Community Hub models in Michigan. That experience can be very helpful, but these are some sources. We will be sharing these slides with you after this program, and I believe the recording will be available as well. But these are some, I would encourage you in every state that I've presented in, I've said this, that I encourage you to get together in groups and just do some studying on this stuff, to go to school on this, so that you can be a strong presence in the room when these issues are discussed, which they will be. So we're going to be doing a quick poll here. Let's go ahead and do that. We're going to wrap up pretty soon. So Miranda, if we
I'm
could
working on getting that set up right now.
Okay, well, I'm going to flash on to the next slide. Just to acknowledge the National Association of CHWs and MIDSHWA sponsored this workshop. But the development of the workshop was paid for by the Community Health Worker Association of Rhode Island and the Rhode Island Department of Health. And we're very grateful to them for their help with this. And we're going to close with that, but I would like to see if we, Miranda, how are we doing? There we
I believe
go.
the poll should be launched.
Great. And Miranda, you're familiar with how to download the results?
Yep, I will do that.
Great. So we'll give this a minute or so. Getting good response numbers. Thank you very much. Yeah, we're still going, so we need to leave this open for a minute or two more. Wow, this is great. While we're doing that, if you have any last minute questions or thoughts, please go ahead and put them in the chat. We only have about 5 minutes left, so.
I'm keeping an eye out for any questions. I'm not seeing any yet.
Yeah. Okay. Well, I got to give y'all a lot of credit here. This is number one, the participation, the level of interest in this is just really phenomenal. This is the biggest session of this kind that we've had so far. And Okay, let's go ahead and close it out, I think.
And I will download those results for you.
Great. Okay, so just a couple of minutes left to go. So let's see if anybody has sort of closing thoughts or questions. And thank you for the kind words, Carol. I'm doing better, but
The question about Mishwa doing follow-up sessions.
yeah,
We'll definitely be brainstorming after this on how to keep everybody engaged with this advocacy process. So we'll be in
yeah.
touch for sure.
Sure. And obviously we don't expect all 150 or however many of you were on this call to be actively involved, but it is vital that some number of you, this is something that NACHW strongly believes in and advocates, that you need to be at the table when these decisions are made. So and hopefully there will be ways for us to provide some further support to you. But if you have a good, solid cadre of CHWs and allies and advocates, of course, who need to be with you, but we need to have a good, solid core of CHWs who are prepared to really get in there and engage and speak to what your interests are. Okay. Would like to see more trainings for CHWs and more gathering opportunities than the once a year training. Okay, good. And again, we went through a lot of material real quickly. So you will receive a copy of the slides, and I encourage you to review them more carefully and to look up answers to other questions you have. Oh, and thank you. Some therapy instructions here. Thank you, Marianne. I'm a big fan of ginger tea, so. Okay. Well, thank you all very much. Miranda, you have closing comments before we?
I just wanted to say thank you, everybody, for coming. I'm super excited about the turnout today. I did mention in the chat, I will send a follow-up email at least by tomorrow about CEUs and with the PowerPoint. And then someone mentioned not seeing a confirmation about registering. This will also be posted on the registry. So you should still be able to get your CEUs because it'll be there even for people who weren't able to make it today. So I will, at least by tomorrow, have a follow-up on that for you. And thank you, Carl, for being here. We really appreciate it.
Oh, it's my pleasure. I just love doing these things. Whoops, lost my, there we go. Okay. I just love doing these things, and we learn more from each of them as we do them that we can share with each subsequent state. But we are thinking about doing some follow-up sessions in more detail about what it takes to prepare and submit a state plan amendment, for example.
Yeah, that would be great. Definitely just kind of keep in touch. I'm sure everybody would be happy to have some follow-ups as things progress. So
That's great. That's great. Well, again, congratulations on the turnout and the interest. And, by all means, whatever we can do from NACHWA to be of help. Certainly encourage you to use the NACHWA document resource center, which has a lot of stuff on policy development. It's available through the NACHWA website. You do not have to be a member to access it. You just pull, you can get it from the homepage of NACHWA, go to the policies menu, and you can access it from there.
awesome. Thank you so much. Thank you again, Carl, for being here and for everyone for coming. And I hope you have a great
My
rest of your
pleasure.
day.
Great. Thanks,
Have a
everybody.
great day. Be safe.
All right.